Assessing and treating the whole child. WHO-ICF model within an IPP framework. What is the WHO-ICF model? The International Classification of Functioning, Disability, and Health, known more commonly as ICF, is a classification of health and health-related domains, including speech-language pathology and audiology. ICF is the World Health Organization framework for measuring health and disability at both individual and population levels. Because the functioning and disability of an individual occurs in a context, ICF includes a list of environmental factors. ICF is endorsed as the international standard to describe and measure health and disability, including diseases, disorders, injuries, external causes, signs and symptoms, functional descriptions, and interventions. Social impact is an important component of the model. Unique cultural and values. The WHO-ICF model was designed to demonstrate sensitivity to the unique culture or values of clients. The dominant culture is the mainstream culture. That is defined as the culture that is predominant within a large majority of the population residing in a society. In practice, many of the assessment instruments and practices, as well as intervention approaches used by SLPs, are designed for the dominant culture. Non-mainstream experiences and values may include issues related to ethnicity, dialect, gender, expression, gender, identity, national origin, including primary language, race, religion, sex, sexual orientation, socioeconomic status, and the medical or mental health factors. By viewing the whole child in his or her functional environments, the child's culture can be observed and considered in your evaluation. Using the WHO-ICF model. There are 7 components of the WHO-ICF model. The model is designed to assure the whole person is considered when developing a treatment plan. Assessment data, including A, body functions and structures, B, activity and participation, and C, environmental and personal factors, are all assessed. Clinical reasoning is used to develop a diagnosis. Finally, goal setting occurs. Step 1, assessment data, environmental and personal factors. If you look at the far right, you can see some of the environmental and personal factors in their example. Johnny is 4 years old and attends Head Start preschool. He enjoys preschool where he interacts more often with teachers than with peers. Johnny has access to speech and language services. He lives with his mother, who has a learning disability, and a grandmother who has a hearing impairment. Johnny and his family live in a low socioeconomic neighborhood. English is the only language spoken in the home. So we know the report sources. We know the client's name and chronological age, daily environments, including homeschool, neighborhood SES, and other, with short notes on how the client functions within those environments. Significant medical and or developmental history goes here. Languages spoken in daily environments goes here. Unique cultural or values of the client would also go here. Step 2, interprofessional input. Assessment data, also under environmental and personal factors. IEP or IPP, multidisciplinary interprofessional meetings held where the client was discussed by a full team of doctors, occupational therapists, nutritionists, teachers, special educators, behavioral specialists, etc., are important to refer to. Refer to input and insights gained from that team meeting, including plans for collaboration and treatment. Step 3, assessment data, body functions and structure. In this first column on the model, you can see that in this place, a lot of the standardized assessment as well as observational assessments go. In their example, they show a test of morphology, narrative skills, receptive vocabulary, expressive vocabulary, articulation, voice fluency, and literacy skills. So in this location, assessments are utilized with the client. You provide a brief summary of major assessment findings and results using the WHO-ICF classifications. State the diagnosis, what modifications of assessment instruments or processes would you use to consider the cultural or value differences of the client. Step 4, assessment data, activity and participation. In the example, you see information about social understanding. Johnny has difficulty making friends and being included in other children's games. He has difficulty joining in conversation with his peers. He has difficulty communicating independently with unfamiliar adults. He also has difficulty telling adults about past events. Johnny enjoys having family members read to him. So this section summarized the main findings related to social skills and gave the referral sources. There's information about speech-related communication challenges, social communication challenges, nonverbal communication, such as eye contact, facial expressions, body language. Be careful and consider cultural norms because there are differences in how eye contact and body language are used among different cultures. Non-literal, ambiguous, inferred meaning, and written language challenges, as well as pragmatics, appropriate talk for the context, following conversational rules, adjusting for listener needs. So with these 3 items, we have a broad picture of the child, how he functions within different environments, what the test scores show us, and what are some of the social participatory issues. From that data, you start to develop clinical reasoning. You use clinical knowledge and judgments to identify the most critical needs to improve functioning at this time based on the data. You decide which impairments or challenges most affect functioning in this setting based on clinical assessment and individual family and caregiver report. You determine what activities are most important to the individual in the current setting. You determine what personal environmental characteristics help or hinder participation in activities or situations in the current setting. And you include an evaluation of the unique cultures and values of the client. So using all of these considerations, you set out a priority for what can we do in intervention that will make the largest and most important functional changes so that the child can operate more effectively in the environments. And that leads to goal setting, beginning with the long-term goal. In this case, Johnny will improve his skills in phonological awareness and grammar, defined as word forms and sentence structure, and his willingness and ability to engage socially with peers. So we have a phonological awareness reading goal, we have a grammatical goal, we have a social goal. So the long-term goals must be written in behavioral terms. This should be an outcome of the ICF Clinical Reasoning. You select aspects of the profile that are most relevant and critical to improving functional outcomes at this time. Some may become more important 3 months from now after these foundational abilities are established. And as always, you include cultural considerations and how you will be culturally sensitive in your treatment approaches. Step 7, goal setting, short-term goals. In our example, by the end of the school year, Johnny will correctly use age-appropriate sentence structures, and then they define them as compound sentences joined by and, or, and but in at least 4 out of 5 opportunities when answering questions during circle time. By the end of the school year, Johnny will use correct past tense in at least 9 out of 10 opportunities when retelling stories during group time. There were other additional goals, short-term goals, including interacting with peers appropriately. So you identify the short-term goals written in behavioral terms. These should be measures directly related to the long-term goal. All elements of the long-term goal should have a measure. All short-term goals should be culturally sensitive. That leads to step 8. Step 8, evidence-based intervention. You must identify the intervention approaches you will use. These must be related to your short-term goals. Explain how you will be culturally sensitive to any cultural or value differences in your treatment approach. Provide the name of the approach, if it has a name, and a short description of the approach. Then provide the supporting data derived from an empirical study. You must show that there is research that supports the use of that intervention to address that specific problem. Include the in-text citation using APA format. Step 9, prognosis. It would be important to also include findings from empirical studies with in-text citations given in APA format. Present the data indicating percentages or other statistics that manifest different outcomes. Also address the impact of unique cultures or values on the client that can have any health or outcome. We know in children with language and learning disabilities, this is often a lifelong problem. As adults, the students may continue to show deficits in their ability to function socially, to hold a job, to graduate from high school, etc. Interprofessional practice. SLPs regularly collaborate with other educational and medical professionals. The interprofessional practice, or IPP, is more than a joint meeting such as an IEP. It's an intentional approach to collaborate that helps professionals learn about, from, and with colleagues from different specialties. In other words, you start to understand the role of the psychologist or the social worker or the behavioral specialist, and you begin to share knowledge with each other so that they understand more how language contributes to those issues, and you understand how those issues can be dealt with effectively when you are working with the child. And you also talk about how you can team to work together. IPP team members each provide their professional expertise and work together on an assessment and treatment plan. The plan centers around the person and their family. The teams collaborate on planning and developing solutions, taking into account each member's perspective. Participating in an IPP team can involve short-term collaboration or ongoing support over several years. Specialists from regular and special education, medical fields, social workers, psychologists, behavioral specialists, and others work together, some ongoing and some as the need arises. Interventions ideally involve working as teams to address components of the child's needs in collaboration. For example, push-in therapy, where the SLP works inside the regular classroom, or collaborating with a special educator on the same reading plan, with the SLP addressing the language within the story and the special education decoding. In summary, the WHO is an international agency that seeks to provide universal definitions of all health and health-related domains, including the wide range of communication disorders. One model, the International Classification of Functioning, or ICF, is used across health and disability areas to provide a holistic framework for assessing all individuals presenting one or more medical or other challenges. This model works well for SLPs who need to identify functional goals and determine if the outcomes are making a difference in the child's ability to function in everyday environments. The Interprofessional Practice approach, or IPP, provides a framework to make an ICF plan maximally effective.